kind of think about there. Fluid balance. Fluid balance and electrolytes are always challenging. Remember, with fluid balance, fluid is constantly shifting between the intravascular space and the intracellular space to try to maintain proper dilution of a variety of different electrolytes, as well as to maintain homeostasis in terms of the correct amount of pressure that's within the vascular to maintain and sustain life. So we're constantly having shifting of fluid. A really good way to quickly determine what someone's fluid balance is, it's non-invasive, would be blood pressure. It's quick, it's non-invasive, it can give you a good idea of what someone's fluid balance is, whether they're high or whether they're low, because we learned that excessive fluid volume can increase blood pressure, and inadequate fluid volume can decrease blood pressure. But the thing to consider with blood pressure is there are other things that also determine a blood pressure besides just volume. And that would include vascular resistance. So if we have increased or decreased vascular resistance, that could alter our blood pressure and may not be reflective of volume, but it's a good place to start. We can also monitor intake and output. Sometimes it can be really difficult to get a really accurate intake and output. There's a lot of potential human error that is involved with that, but it is a good way. The most accurate way to assess someone's fluid volume is a weight, and not just one singular weight, but a trend of weights over time, over a period of subsequent days. We can tell what someone's volume status is by checking daily weights. We know that 1 liter of fluid is equal to 1 kilogram of weight. And so if we're weighing a patient, every day, and we see an increase or a decrease in kilos on our patient, we can then know that that is directly related to weight, because a normal person, even though my husband likes to think this, doesn't lose actual weight in a day or two. It takes time. So if you're seeing an increase or a decrease in a day or two in that weight, it's a fluid. Same goes for yourself when you step on the scale. And that's part of why we teach patients. If you're gaining, X amount of pounds, 2 to 3 pounds in 24 hours, that's not normal. We don't gain weight that fast. That's a fluid thing. We can also look at skin turgor and mucous membranes. Those are physical assessment things. Oftentimes, those kind of clue us into that there may be some kind of fluid issue, but again, they're not the best determinant of fluid balance, not like a weight actually is. And then osmolality, that's going to be like a urine sample that we get. It can tell us how concentrated or dilute our urine is, and that can be also something that we look at there. As far as intake and output, of course, we take in fluid orally most of the time. By drinking fluids, we get fluid that comes in by foods. Different foods have different amounts of fluid in them. And then in, of course, the acute care setting or the medical world, we can also take fluids in through the intravenous route. As far as losing fluids, there are ways that we lose fluid that we can measure. Those are going to be our sensible types of fluid loss, would be something like urinary output. If someone has a nasogastric tube, we can measure that urinary output. So anything that we can actually measure, we consider that to be a sensible form of fluid. Now, if we are not able to measure it, that's considered insensible fluid loss. And we account for those things, but we can't specifically quantify them. So like this gentleman, he's sweating excessively. He's gonna probably need a couple of drinks of water to help replace that fluid that he's getting. If someone is tachypnic, we know that we lose fluid through breathing, and so that would be something else that we consider in terms of a patient's fluid balance. But sensible fluid loss we can measure, and insensible fluid loss we cannot measure. So hypervolemia, this is when our body is holding on to too much fluid. We can have an actual increase in fluid, but it's typically coupled with a decreased output of fluid, or something is happening there where our body is not able to regulate the volume of fluid that's in our body. And, our kidneys are integral in maintaining fluid balance and fluid volume. They release fluid, they hang on to fluid in response to, kind of like the level of fluid that's circulating through the bloodstream. And some conditions can predispose people for becoming hypervolemic, such as congestive heart failure. Very classic group of people who can easily become hypervolemic because their hearts are weak and they don't pump hard enough. And so we're not getting adequate perfusion to the kidneys, because the kidneys are they have to be perfused. That's how we make urine, because it filters the blood. So CHF patients are high risk for hypervolemia, but really anybody that's getting large amount of volume can be at risk for hypervolemia. We see those things like the respiratory things that we talked about, like with the taco, where you have shortness of breath, tachypnea, hypoxia, crackles in the lungs, that kind of thing. We also see an increase in blood pressure and heart rate because our body's trying to manage that excessive volume. We can see edema, especially if it's happened over, a period of time as opposed to just an hour or so. Our goal is to get the fluid off. So we can do that either by restricting the amount of fluid that a person takes in and letting the body take care of it. If that's the issue, if it truly is an excessive intake problem, we can also pull the fluid off through something like the use of a diuretic, where we encourage the kidneys to release fluid. We do have to be concerned about electrolytes, especially potassium and sodium, when we utilize something like furosemide or a loop diuretic, because we can end up with that. But, it'll work. If a patient's a dialysis patient, that patient's kidneys already don't work, of course, they're going to be at risk for volume overload. They might have to go to do a run of dialysis. So whatever is leading to this volume issue. So if it's, a kidney problem or a heart problem, we're going to fix that so that we can, for the long term, manage the volume issue. But in the short term, we have to get rid of the fluid. And again, this goes back to understanding how we can monitor fluid volume on a patient, monitoring blood pressure, monitoring heart rate, looking at those daily weights, keeping track of intake and output more closely in these patients, just so you guys know. And I run into this a lot, and I try to educate the doctors, and they still don't get it. I always get flack from the renal doctors, the nephrologists who are taking care of dialysis patients, and the cardiologists. And they say, how come you're not getting daily weights? This is a CHF patient, and this is a dialysis patient. And I always tell them, well, if you don't put in an order for the nurse to get a daily weight, it's highly likely that they're not going to get a daily weight. And while it is reasonable to assume that if someone has that diagnosis of CHF or renal failure, that one would get a daily weight, you have to understand that as newer nurses, we don't remember all of that stuff. So just put the fucking order in for the daily weight and we'll get it, and stop complaining that we're not getting it. So just FYI, you don't have to have an order to get a daily weight. So if you're taking care of a patient who has a risk for hypervolemia, you can absolutely independently, without an order, get a daily weight. And when you see those doctors, don't talk to them like I do, but you might say, hey, do you want me to put an order in for a daily weight? So you have the power to get that if you want to. You don't have to have an order. The other side of this is hypovolemia. This is our dry patient. This is typically either because of an excessive loss of fluid or because of a poor intake of fluid by our patients. It could be with hemorrhage. That would be an excessive loss, and that'd be a little bit different if our patient is hemorrhaging. Not only are they going to have that hypotension and that tachycardia and feel really thirsty, things like that, but they're also going to have low hemoglobin and hematocrit, and they're going to have those signs of hemorrhaging like pallor and that sort of thing. But we can also have a hypovolemia where it's truly just a fluid loss. Mucous membranes are going to be dry because the body's trying to suck fluid out from every place that it can to put it into the vascular space. And so that's why you see these dry patients. Orthostatic or orthostasis, which would be when the patient stands up, they kind of get dizzy and lightheaded. That's pretty common with hypovolemia. Really what we want to do is we want to replace the volume of fluid that's lost. So anytime someone is not able to access fluid, they have some kind of condition where they are excessively losing fluid, whether that's bleeding, excessive urination, high use of diuretics, someone who's on a bowel prep where we're making them lose a lot of fluid to prepare them for a procedure. I was thinking of another one that was really good. I can't remember. Anyway, anytime something like that is occurring, we have to monitor for them for hypovolemia, and then of course replace that volume. And then once we understand what's causing that hypovolemia, we can then correct that underlying cause. Sodium. I think this is the normal range for sodium. Sodium really controls fluid balance within the body. It makes fluid shift from one place to another, and brain cells are the most sensitive cells in the body to this shifting of fluid. And this is why a lot of the signs and symptoms that we see with high and low sodium are neurological in nature. So just a reminder of that there. Hypernatremia typically occurs in someone who has a low fluid volume, and so the sodium becomes very concentrated. So oftentimes your hypernatremic patients are also hypovolemic. So not only are they going to experience that hypovolemic symptoms like what we just talked about, but they're also going to have those neurological changes that are associated with an elevation in sodium. Oftentimes it's hard to identify this other than the hypovolemia, or we see it on a lab value, but there are people who are at risk for elevated sodium, particularly those who are at risk for not getting in enough fluid volume, like people who can't get up and walk to the bathroom or to the sink in the kitchen to get a drink of water, or people who can't reach their cup of water on their bedside table, or people who are cognitively impaired who don't realize that they need to get something to drink, like Alzheimer's. Alzheimer's disease is a really horrible disease that affects the brain, and the brain kind of goes backwards in development to the point where all of those things that we learned in as children, like bladder and bowel control and intake control and all those kind of things, goes away. So those patients, you really have to remember that they need extra fluid. Too little sodium or hyponatremia can be because of an actual loss of sodium along with water. That would be a hypovolemic hyponatremia. So not only are you going to see signs and symptoms of hypovolemia, but you're also going to see those neurological changes associated with low sodium. And it's going to be those types of patients who are losing lots of fluid, whether it's because of excessive diuretic use, or people who have a lot of loss through their GI system, whether it's diarrhea or maybe excessive nasogastric suctioning or something like that. Those are places where the body loses sodium and fluid, and so they're low on volume and they're low on sodium. So you see a combination of those types of symptoms. Now, if a sodium gets too low, it could be you're going to start to see a worsening in symptoms. So once a sodium is below the level of 120, that's considered very critical. Your symptoms are probably going to get much worse at that point. And when we correct those low sodiums, we have to do it very slowly because we're trying to avoid damage to the brain. For high sodium too, if our sodium is really high, we have to correct them very slowly because we're trying to avoid either cellular swelling in the brain or demyelination of neurons in the brain. So you have to be careful with sodium correction. I think the parameters are no more than 4 milliequivalents in about 2 to 4 hours. So when someone has really low or really high sodium, we're checking those sodium levels pretty frequently to make sure it's not going up too quickly or going down too quickly, because then we have to adjust our therapy. Now, someone who has hyponatremia in the setting of excessive volume is likely going to be your patient who is someone like our congestive heart failure patient. In that instance, we look at the lab and we see that the sodium is below 136, but we're going to restrict sodium because it's a dilutional issue. That patient is over diluted. So we don't need to pump more sodium back into their body. We need to get rid of the fluid, really, is what we're doing. So those patients are going to get things like diuretics, fluid restrictions, so that we can pull off the fluid and thus resolve the concentration issue of the sodium. So we're going to put them on a low sodium diet. We're going to make sure they're not taking in excessive amounts of oral fluid, and we're going to give them diuretics to pull that fluid off there. Potassium, my favorite. Just like ice cream, I love ice cream. So I put this picture here. First of all, bananas always remind us of potassium. That's a good way to get potassium. We need potassium replaced in our diet every single day because our body doesn't make it. Our kidneys are responsible for controlling potassium. It actually gets rid of potassium pretty well for the most part. Doesn't really hold on to it the greatest, and that's why we have to have replacement of potassium in our diet every day. Another reason why I put ice cream on here is because I heart ice cream. I love ice cream, and that's just a reminder that potassium has a really significant effect on cardiac rhythms. Does it affect other things? Absolutely, it does. But your cardiac effects of high or low potassium are probably the most critical that we are concerned about. It not only can affect blood pressure and heart rate, but it also can affect the electrical activity in the heart. So that's both for high and low. Now with high potassium, when it comes to electrical activity, what we're going to see is a tall peaked T wave. That's pretty classic of a hyperkalemia. You might notice that on your cardiac rhythm before you even recognize that the patient's potassium is high. You go in and you check the labs and you're like, oh, look at that, the patient's potassium is high. Potassium, you can see, has a very narrow therapeutic range. So it doesn't take long for that to become very dangerous. Once your potassium level starts to get up around 6 and 6.5 and 7, you're going to see additional cardiac electrophysiology changes where that everything starts to widen out. So the PR interval becomes longer, the QRS complex becomes wider, and ultimately what's happening is that patient's cardiac electrical rhythm is moving towards VTach, and ventricular tachycardia is a deadly cardiac arrhythmia. So that's not a good thing. Now with a low potassium, typically what we see is, in terms of cardiac electrical rhythm, is the T wave becomes flattened. So if you start to see a flat T wave, you can pretty much bet your bottom dollar that you have a low potassium. GI symptoms are pretty common with potassium alterations, whether it's high or whether it's low. It's a weird kind of thing. Patients, I always find this odd, patients, when they have excessive vomiting, causes their potassium to go low, and then the low potassium causes further nausea and vomiting. So we can help patients who have that nausea and vomiting with the low potassium by replacing the potassium. So it's just a weird thing. But either way, GI effect can occur because of low or high potassium, as can numbness and tingling. Patients can have paresthesias, numbness and tingling because of high and low potassium. If your patient has high potassium, those who are most at risk for that are going to be those people who have kidney issues, because as I said, our kidneys actually do pretty good at getting rid of potassium. So if our body's not getting rid of potassium, it could be some kind of issue with the kidneys, whether it's an acute renal issue or a chronic renal issue or whatever. There are times which patients take in too much potassium. A really common instance is people who use salt substitutes. Salt substitutes are actually made of potassium something, I forget, but Google it, look up salt substitutes and see what ingredient is in that. It's potassium, because that potassium is really salty. So people who shouldn't take in sodium will use a salt replacement for that. So those people are at risk. Or if we're giving someone medications, or someone's taking medications that cause them to hang on to potassium, certain things like ACE inhibitors can do that. Potassium sparing diuretics can do that. So those are the people you're watching more closely, because you know they're at risk for hyperkalemia, regardless of what it is. If a patient has an elevated potassium, we got to get it down. We can do that. Let's see, we can do that by dilution. That's where my train of thought was going. Anytime we have a potassium or magnesium or, even sodium, we can dilute it out. We can give fluids. That's going to take a little bit of time. So, that's okay. If our potassium is not too high, we can use some sort of intervention that can lower the potassium level a little bit more slowly. If we start to have someone who has those high critical potassiums, where we're up around 6 and 7, and we're starting to see electrophysiology changes, we have to get that potassium level down much more quickly. And so we would utilize something like insulin. Now, I know insulin we typically think of in the setting of diabetes, but insulin actually encourages the movement of potassium into the cells. So that's a good thing. If we have an elevated serum potassium, let's push it inside the cells, and our serum potassium will go down, and therefore it's not available to do crazy things to the cardiac muscle and electricity. But because we know that insulin can affect blood glucose, we have to account for the fact that when we give insulin for hyperkalemia, we're also going to drop a patient's blood sugar, because we will implement this therapy not just for diabetic patients, but for any type of patient that has a critically elevated potassium that we need to lower very quickly. So to do that, we give the patient dextrose. So that's a pretty common order. We can also give a medication called Kayexalate, or sodium polystyrene sulfate is the generic name for that. That's going to take a little bit longer. So again, probably not the best choice for patients who have really critically high symptomatic hyperkalemia, but effective nonetheless. It's a liquid. The patient drinks it, and I think it's like Fruity Pebble flavored, I don't know. And I feel like it can be given as an enema too, which weirds me out. If you can drink something and give it as an enema, I don't know, just seems bizarre. But anyway, it works by pulling potassium into the colon, and then it binds to that potassium, and then it's evacuated with the stool. So an expected response for someone who is taking Kayexalate would be loose stools, just FYI. I always warn my techs when I'm about to give Kayexalate so that they know, or a diuretic if I'm about to give Lasix, which is something else we can give to lower potassium. If the potassium is low, if they're hypokalemic, of course, anybody, as I mentioned, has risk for excessive losses, like excessive diuretic use, or vomiting or diarrhea or something like that. We're going to replace it. Anytime we have a low electrolyte, for the most part, we're going to replace it. Sodium's unique, but these others, we're gonna add it back into the system. We can give potassium orally. There are capsules and tablets that can be administered. They're huge. I mean, seriously, they're really big. Make sure you've got suction set up before you administer little people potassium capsules or tablets. I've had to do the Heimlich on a patient before because they choked on their potassium. You cannot crush potassium, and so for people who have difficulty swallowing, that can be a challenge. The other thing about potassium that's really fun is not the capsules, but the tablets oftentimes melt if you don't get them down quickly enough. And so if a patient doesn't get them with a good swallow, they kind of get stuck in the throat and start to melt. So don't ever leave potassium, well, you don't ever leave any medications laying around for a patient to take and then walk away. But whenever you're giving pills or capsule potassium to a patient, make sure you're right there with them until they for sure have gotten it down. There is liquid potassium, potassium chloride, which is salty. So Christina, thank you for looking at that. That does make sense why it would make a good salt substitute. It's disgusting, tastes awful. It's recommended that you dilute that before you give it to the patient. However, you don't want to dilute it so much that they have a large volume to drink because it really does taste that bad. It's very salty. I've seen it come back up as quickly as someone has shot it down. So it's just, there's just no good way to give oral potassium. We can also give IV potassium. We never give IV push potassium. That will cause someone to go into a deadly cardiac rhythm and kill them. So we never, ever, ever give IV push potassium, but we can give it through diluted through an IV piggyback route. We do that all the time. We have to be careful on how fast we can give it. We can give it on our med-surg units at 10 milliequivalents per hour. So normally a potassium is diluted in a solution of like normal saline or something. And so we might have 20 milliequivalents and 50 milliliters of saline. So we would give that, 25 milliliters per hour. That would be 10 milliequivalents an hour. So no faster than that on our med-surg units. It burns really badly when you give it parenterally or through the IV. If someone has a central line and a peripheral line, it's always best to give it through the central line. But a peripheral line, you really have to monitor that IV site. It can cause tissue necrosis, but just painful in general. I've had to do some things for patients to help dilute it even further. I've had to slow down the infusion. Sometimes putting ice on the vein kind of helps a little bit. Sometimes heat will pop open that vein, like dilate it, make it a little bit more comfortable for the patient. But not only can it burn like locally at the site, but I've had people complain of pain all the way up the arm. So things to monitor for with potassium. I've even had to stop it before. My personal experience with potassium is if a patient can take oral potassium, is better than IV potassium, and not just because of the burning issue. It kind of sticks better. I don't know, that's the best way I can describe it. When patients take oral potassium, when they're able to, it seems like the levels respond better than they do to IV potassium. I don't know why that is. I don't know if there's research or evidence behind it, but just personal experience. Magnesium, I think this is a good range, 1.3 to 2.1, that sounds right. Think about magnesium is it helps to produce energy. It also affects vasodilation, which means that it can impact blood pressure as well as cardiac output. It has an effect on sodium and potassium in their ability to transport across cells. And it's regulated in the GI system where it's absorbed in the small bowel. So anytime we have some kind of issue going on in the GI system, we have a patient who's at risk for altered absorption of magnesium. If a magnesium level is elevated, This is typically because of some kind of kidney issue. Maybe they have a chronic renal problem where their bodies can't get rid of magnesium, or it's because they're taking in too much magnesium, most commonly because of they're laxative junkie and they're taking a lot of like magnesium sulfate or milk of magnesia or something like that. Or B, we are giving them magnesium because their magnesium level was low and now we've kind of overshot the mark. If a patient's magnesium is high, if they have hypermagnesium, it really has a sedative effect and it diminishes cell excitability. And so we see things like lethargy and weakness, hypotension and bradycardia, and even cardiac arrest. You can see Felix on the right there, how he just kind of melts into the chair. Does anybody even remember Felix the cat? Pete, you might, you're old. But I know everybody here knows who these people on the left are, because this is newer things. But Felix, you know, he's got hypermagnesemia. He's melting into the chair. Now, if a patient has a low magnesium level, they're going to have hyperactive deep tendon reflexes and tremors and tachycardia and tetany. And that's what, what's his name? Oh, what's his name? The guy that's fainting, Neville. Neville, he's very tetanied, right? So he's really stiff. So that's what happens when your magnesium is low. So tachycardia, tremors, tetany. You can even have emotional lability with a low magnesium. Ageism, that's right. That's right. You got me. Most common reason why patients have low magnesium is we're losing it for them. You know, diuretics or something like that. But also alcoholics. I see a lot of alcoholics have low magnesium levels, so we need to monitor them for that. Another thing to remember about hypomagnesemia is it's very common for patients to also have a low sodium or a low potassium if their magnesium is low. So just something to think about. You might want to check those if your magnesium's low. I feel like I was going to say something else about hypermagnesemia, but I can't remember. I think it had to do with hypermagnesemia. Oh, I know what it was. I'll go back, so we're looking at magnesium. If your magnesium is elevated, don't forget, because it can have cardiac effect. To protect the heart against that cardiac effect, we might give calcium gluconate for that. It's considered the antidote. Okay, calcium, 9 to 10.5 has a really fun relationship with phosphorus. It's an inverse relationship. So if calcium is high, phosphorus is low, and vice versa. In fact, our symptoms that we see with phosphorus alterations are because of the alteration that is experienced because of calcium. It has an effect on both cardiac and skeletal muscle. Our body needs vitamin D to be able to absorb calcium, and calcium is important in bones. Low calcium can cause tetany and muscle tremors, as well as cramps and paresthesia, especially oral paresthesia with a low calcium. What you see being performed here is they're tapping on that facial nerve to test for Chopsek sign. And you can see that this gentleman has a bandage on his neck because he probably had a parathyroidectomy, meaning he had his parathyroid glands taken out. And so when we get rid of that, parathyroid gland, we're no longer secreting that parathyroid hormone, our patient's at risk for hypocalcemia. And so we're monitoring. That's what this person here is doing. They're monitoring for low calcium. A dangerous thing that can happen with hypocalcemia because of muscle like tremors and tetany would be a laryngeal spasm. That's going to compromise the airway. So anytime someone has a parathyroidectomy, we are supposed to keep a trach kit at the patient's bedside to perform a potential emergency tracheotomy if the patient experiences laryngeal spasm. That's always a fun thing to remember. If someone's calcium is low, we're going to replace it. You have calcium chloride or something like that. If somebody has high calcium, we're going to see the opposite. We're going to see, as opposed to that tetany and tremors and cramps and stuff like that, we're going to see lethargy and weakness. Patient is going to be at high risk for cardiac arrhythmia, so we need to be monitoring their heart rhythm, place them on the heart monitor, keeping an eye on that kind of thing. And what we're going to do is we're going to dilute it, give them lots of IV fluids. We can give them medications. Calcitonin encourages the movement of calcium from the bloodstream, which is how we know someone has high calcium, into the bones, so that can help move that. Or they might get dialysis. If they're a dialysis patient, we often see elevated calcium levels on our dialysis patients.